antibiotic course, but missed his follow-up schedules, appointments. He currently takes no medication. He said he feels well. The exam show no abnormalities. Which of the following is the most appropriate next step in management?
Okay, it's number 41. Okay, wait.
Oh, okay.
Okay. Mm, okay, it's pneumocystis zerovici, mm, trimethoprim sulfamethoxazole prophylaxis. Pneumocystis zerovici is an opportunistic yeast-like fungus. It's an opportunistic yeast-like fungal organism that can cause pneumonia. That can cause pneumonia in immunocompromised patients. In immunocompromised patients, including those with poorly controlled HIV infection. Chest imaging is typically shows diffuse bilateral infiltrate, often prominent about hila, methamine silver or toluidine blue stain, methamine silver or toluidine blue stain, selectively stain selectively stain the cyst wall and are used to confirm the diagnosis. Patients with HIV infection who have CD4 count below 200 are at risk for developing pneumonia from pneumocystis zerovici. Given these patients' lack of antiretroviral therapy, recent history of pneumocystis zerovici prophylaxis against recurrence is indicated. Treatment consists of trimethoprim, sulfamethoxazole, atovaquone, pentamidine, with trimethoprim sulfamethoxazole serving as the first-line preventive therapy for patients with HIV infection, and a CD4 count is less than 200. All patients with newly diagnosed HIV should started on 3 antiretroviral drug. Okay.
Okay. 37 woman comes to physician for evaluation of malnutrition secondary to systemic sclerosis. 6 months ago, she had an elective abortion because of her poor medical condition and has had 20 pound weight loss since that time. She says she has difficulty falling asleep. She awakens daily at 4 a.m. and cannot go back to sleep. She's like 5'8" and like BMI is super low. Physical exam shows no abnormalities. On mental status exam, she's sad and tearful and reports feeling hopeless. Her serum albumin concentration, I believe, is low. In addition to aggressive nutritional support, which of the following is the most appropriate pharmacotherapy?
Okay. Patient falls on major depressive disorder criteria like
Mm,
5 out of 9 criteria. Okay,
mm,
find out 5 out of 9 criteria.
okay, she has weight
Weight
loss.
loss and difficulty in falling asleep,
Yeah.
sleep problem,
Mm,
weight gain. No, wait, not
weight
weight
loss.
gain. Weight
The other day,
loss. He's
and
sad, depressed
sad.
mood, and feeling hopelessness.
Okay, that's four. I mean, I guess 4, 5, kind of the same. Yeah. Mhm.
Okay. So this patient, 2 or more weeks of at least 5 out of the following symptom: depressed mood, anhedonia, guilt, anhedonia, guilt, or worthlessness, difficulty concentrating, and psychomotor delay, suicidal thoughts, or neurovegetative symptoms, decreased energy, sleep disturbance, appetite disturbance, leading to weight changes. These symptoms disrupt everyday functioning. These symptoms disrupt everyday functioning. MDD is common in patients with autoimmune disease like systemic sclerosis, where inflammation, has been implicated in the pathogenesis. Symptoms of MDD and systemic autoimmune disease, but commonly overlap fatigue, decreased appetite, making two conditions difficult to distinguish. However, a sad, tearful mood, hopelessness, and psychological symptoms that somewhat specific for MDD and can assist the patient and can assist physician with determining to diagnose. As also these patient symptoms begin after abortion, which appears to have been a major stressor. Ab- Abortion have been associated with onset of major depressive disorder, and in some patients, treatment of MDD includes psychotherapy, antidepressant therapy, SSRI, first line antidepressant. Okay,
Can you read B D? Yeah,
BD.
B.
Okay,
B.
dronabinol. Dronabinol is a synthetic tetrahydrocannabinol. It is used to treat chemotherapy-induced nausea and vomiting. Dronabinol, an anorexia associated with HIV infection and or AIDS, typically used to treat appetite disturbance in MDD. So it is used in chemotherapy-induced nausea and vomiting. And megestrol is a
No, D.
olanzapine is an antipsychotic medication with mood stabilizing properties, particularly used in schizophrenia and acute mania. It is prescribed off label to stimulate appetite in patients with medical illness by addressing the underlying depression. Antidepressants are more likely to address these appetite disturbance than olanzapine.
Okay,
Okay,
next. 72 men comes to the office for routine exam. He underwent carotid endarterectomy and 5 vessel coronary artery bypass grafting 1 and 5 years ago, respectively. He has hypertension, hyperlipidemia, CKD, GERD, medications, clopidogrel, giltiazide, metoprolol, atorvastatin, famotidine, aspirin. He has smoked like 2 packs of cigarettes for 50 years. Temperature is fine, pulse fine, respiration fine, pulse BP is high. On exam, shows no abnormalities. Result, hemoglobin, I believe that's normal. Hematocrit, normal. Leukocyte count, I believe is normal. Sodium, a bit low. Potassium, normal. Chloride, normal. Bicarb, normal. Urea, high. Creatinine, high. Lisinopril is added to the medication regimen. 2 weeks later, the patient returns to the physician for follow-up visit. Pulse is, oh Jesus, pulse is fine. With blood pressure still a bit high. Examination, oh, I guess high normal. Examination is otherwise unchanged. Results of the lab are urea is even higher, creatinine even higher, blood in urine, blood none, protein none, iron cast none. Which of the following is the cause?
so what is your diagnosis?
Um, the ACE inhibitor did something.
Yes.
Yeah.
If it is unilateral renal artery stenosis, then ACE inhibitor does not cause creatinine to be that high. If it is bilateral renal artery stenosis, like if you give ACE inhibitor and your creatinine start rising, so we should think about bilateral renal artery stenosis. Okay.
Okay.
Okay, in bilateral renal artery stenosis, Renal artery stenosis causes secondary hypertension related to activation of renin-angiotensin-aldosterone system. Low afferent blood flow to the affected kidney leads to low afferent blood flow to the affected kidney leads to abnormal stimulation of the juxtaglomerular apparatus and excessive production of the renin. Renin converts angiotensinogen to angiotensin 1. Then it converts into angiotensin 2 with the help of angiotensin converting enzyme in the pulmonary vasculature. Angiotensin 2 is a potent vasoconstrictor, mediates systemic hypertension via sodium reabsorption in the renal tubule. Aldosterone and vasopressin release increase androgenic tone and stimulation of a hypothalamic thirst center. In younger patient, fibromuscular dysplasia is the most common cause of renal artery stenosis, while in the older patient, it is typically caused by atherosclerosis. This patient likely has bilateral renal artery stenosis due to atherosclerosis, evidenced by history of carotid endarterectomy and CABG. An abnormal bruit may be appreciated in the region of the stenosis. Diagnosis established with renal artery Doppler ultrasonogram or renal artery Doppler ultrasonogram or MRI, which can quantify the degree of renal artery stenosis and associated kidney atrophy. Treatment involves angioplasty or stenting of the stenosed renal artery to improve flow. ACE inhibitor can be considered for unilateral stenosis. ACE inhibitor is considered for unilateral stenosis in the setting of in the setting of bilateral renal artery stenosis. However, use of ACE inhibitor will decrease. This one is important. Uh, Use of ACE inhibitor will decrease systemic hypertension and but will lead to acute kidney failure, evidenced by acutely elevated serum urea nitrogen and creatinine concentration in this patient following using of lisinopril. Okay,
62 woman gravida 3 comes to the physician because of a 3-month history of painless mass protruding from her
just
vagina
look
with
at the
bowel.
patient and tell your diagnosis. You cannot say what type of like something is coming out, but you can say your diagnosis, like what is it.
I can say cystocele. I will be between cystocele and uterine sarcoma.
Yes, it is like some uh, is something coming down from per vagina. It may be like prolapse, isn't it?
Uh-huh, uh-huh.
And it is this mass is protruding like anteriorly. Okay, okay, I am reading now. Okay,
Okay.
62-year-old man, gravida 3 para 3 comes to the physician, 3-month history of painless mass protruding from her vagina with bowel movement. She has the sense of incomplete. She has sense of incomplete bladder, incomplete emptying of the bladder. This is one clue. Sense of incomplete emptying of the bladder until she pushes the mass back into her vagina. So this is the clue, like it is cystocele. During the past years, his pelvic pressure with prolonged standing or lifting, his pelvic pressure has increased with prolonged standing. She does not have urine loss while coughing. That means she does not have stress incontinence. She has only prolapse and all her pregnancy uncomplicated vaginal delivery. She has uncomplicated vaginal delivery, 3 vaginal deliveries. So the vaginal delivery is one of the risk factor of prolapse. Okay, now, okay, pelvic organ prolapse. Okay, pelvic organ prolapse secondary to pelvic floor, secondary to pelvic floor dysfunction and weakness resulting in herniation of the resulting in herniation of the abdominopelvic organs, which causes mass effect and protrusion along the vaginal wall. The herniation of the pelvic organ can lead to pelvic pressure as well as urinary, defecatory, and sensory dysfunction. Pelvic organ prolapse is a spectrum of disease, with complete procedentia being a severe form that includes herniation of the entire, either anterior, posterior, apical, vaginal compartments through the introitus. The patient will have a degree of cystocele bladder prolapse, a rectal prolapse, and enterocele intestinal prolapse, respectively, as a result of the descent of the pelvic organ. As a result of the descent of the pelvic organ, in these mm, extreme cases, the cervix and the uterus may be entirely or partially visible at the introitus. However, patient can have less severe forms with isolated prolapse, such as the cystocele seen in this patient. Cystocele is common in multiparous patient, is associated with stress or overflow urinary incontinence, and the inability to fully emptying the bladder. In severe cystocele, the anterior vaginal wall may herniate through the introitus, leading to a palpable or visible mass at the introitus that may enlarge or intra-abdominal pressure increases. Other risk factors of pelvic organ prolapse include advancing age and obesity. Diagnosis of pelvic organ prolapse is made through complete physical examination. Treatment include pelvic floor muscle, vaginal pressure, and surgical repair. Okay, the uterine sarcoma one is a rare uterine cancer, typically develops from the myometrium or connective tissue of the uterus. Symptoms include abnormal uterine bleeding, abdominal pelvic pain, pelvic pressure, abdominal distension. This patient has no uterine bleeding or abdominal pelvic pain. Additionally, as the sarcoma, it is formed in the uterine tissue. It is formed in the uterine tissue. It would be unlikely to be visibly extruding from the vaginal introitus. Okay, it does not like comes out through the vaginal introitus. Okay,
Next. 1 day old male newborn, evaluated in the hospital nursery. He was born at term with a 23-year-old gravida 1 para 1 following an uncomplicated pregnancy and spontaneous vaginal delivery. Apgar score 7 and 8. He has been bottle fed but feeds slowly. On exam, the patient's mother grip strength is 4 out of 5, and she has difficulty releasing the grip. The mother
can you
is
tell me
adopted
the name of this sign? Difficulty releasing the grip.
myotonic.
Yes, grip myotonia.
Uh-huh. Grip
Okay.
myotonic. Okay. What is it? Her husband and the father's family medical history are also unknown. And the patient does not appear to be in distress. He's at the 45 percentile in length, 75 weight, 50% head circumference, temperature fine, pulse fine, respiration a bit high, blood pressure low, pulse oximetry on room air is 98. He does not have a vigorous suck or loud cry. On passive range of motion, muscle tone is decreased throughout. Spontaneous movement are decreased when the patient is awake. Motor reflex is poor. Deep tendon reflexes are absent. Reminder of the exam is normal. Which of the following is the most likely diagnosis? Where did it go?
Okay, in
Mm,
here, apart from the grip myotonia, is there any
mm,
clue you have found in myotonic dystrophy regarding myotonic dystrophy? There is
no.
another clue like 50 percentile of head circumference, like head circumference 50%. I
Also,
don't know what it does mean, but there is a head finding in myotonic dystrophy also. So I
I
guess,
thought 50 is normal. I thought 50 was normal.
okay, may not be. Okay, okay, I'm reading the explanation now.
Mhm.
So myotonic dystrophy is a genetic disorder. It's a trinucleotide repeat expansion. A trinucleotide repeat expansion which occurs as a series of these nucleotide repetition replicated incorrectly and too much repeats included in the replicated product. Other is trinuclear repeat expansion, fragile X. Can you tell me what type of trinucleotide repeat expansion happen in fragile X syndrome?
Hmm. CTG?
No,
No.
CTG is myotonic dystrophy.
Okay. Ah, wait.
Think fragile X is bad, X is bigger. So myotonic. In fragile X syndrome, everything gets bigger. Like macro macroorchidism, like testis is
Mhm.
getting bigger. So CGG. So it is the CGG.
CGG. Wait, how do you correlate the bigger and the CGG?
CGG is in cog gigantism.
Co- in, wait, say it again. CGG is what?
Okay. Cog gigantism, like
Cog gigantism.
yes,
Oh, I get G. Oh, gigantism.
gigant,
Okay.
yes.
Okay, okay, okay. Got it.
Okay,
Makes sense. I like
okay.
that. Okay.
So remember in a bad way that it will be easier for you to remember because uh, it's my way of thinking. Okay, no problem. Okay. And the Huntington. Can you tell me the Huntington?
Oh my goodness, I should know this one. CGG, CTG,
CTG is myotonic dystrophy.
CTG,
CTG,
CTG.
like cataract, 2P, and G for another thing. It is written in the first state, like myotonic
Mhm.
dystrophy. Okay, myotonic dystrophy is CTG, and fragile legs is
It
CGG,
is
cog
CTG.
gigantism, and Huntington is caudate CAG. Caudate loses acetylcholine and the GABA. It is the
Oh,
pathology of the Huntington disease also.
uses acetate.
Acetylcholine and
Oh,
GABA.
CAA? No, CAG.
Sorry,
Wait, so
CAG.
CAG,
Yes, CAG.
acetate and GABA.
And
Whoa.
Frederick ataxia, gait ataxia. Frederick ataxia is a gait ataxia. So
Whoa.
GAA.
I need to write this. This is important.
Uh,
Ah,
these things we actually forgot. So that's why I am just recalling uh, along with the analysis of the question. Okay.
you say trinucleotide repeat. Okay, you say CAG, Frederick Ataxia. Can you repeat it?
Frederick ataxia is an in Frederick ataxia you will get ataxic gait. So that is gait ataxia, GAA. So
Ataxic.
GAA is the trinucleotide repeat expansion.
Wait, it says ataxic gate, so it's ataxic, CAG. Okay, how do you relate ataxic gate with CAG again?
So GA gate. How will we spell the gate? Gate.
Okay, so
So if you
G,
tell the gate the A twice, like write the G double A then IT. You got my point.
no, no. You say the ataxic, the A in ataxic is the A here, and then the G in gate is the G here. So there is no C.
No, in here
Okay,
GAA. The
G.
problem, the trinucleated repeat expansion is GAA.
Oh, it's not CAG.
No,
Is it?
CAG is for Huntington.
Okay, it's GAA. So where does the first G comes?
This gate goes with the G, gate
Mm-hmm.
goes with the G, and
Mm-hmm.
like Frederick ataxia, there is ataxic gate. So GAA is the trinucleated repeat expansion. GAA.
GAA. Okay. And then you say in Huntington.
Okay, look at this now. Okay, I'm sharing my screen. That would
Mhm.
be easier for you. Can you see my screen
Not
now?
yet. No yet. Now.
Okay, look at here. Huntington, CAG, like caudate loses acetylcholine and GABA. It is the trinucleotide repeat expansion. And myotonic dystrophy, I have already sent you myotonic dystrophy. There is CTG, like cataract, 2P, that means early balding, and gonadal atrophy. In myotonic dystrophy, there is gonadal atrophy, but in fragile X syndrome, there is giant gonad. Like uh, in here, they are, I have said in my version, in here they said chin, like protruding chin and giant gonads. So CGG and Frederick ataxia is the ataxic gait. That's
Oh,
what I am
let's
saying. That's what I have said. Got it?
see. Gay, GAA.
These
Oh,
things are
it's
very important.
GAA. It's not
No,
GAG.
no.
It's
CAG
GAA.
is for Huntington.
Okay. You say in fragile X, everything is big.
Yes, fragile X in everything is big. There is macrocephaly. There is large ear. There is giant gonad. And in fragile X syndrome, there is FMR gene mutation, which is found on southern blot or PCR.
Let's see. Ataxic gait. So it's GAA. Got it.
Got it?
Yep.
Okay. Now
Thank you. Oh, let me share my screen.
we will try to be the like uh, master in the topic. That would be helpful in your exam.
Yes. Yes.
So there is nothing to read in here.
No, read it.
Okay.
You were doing the marathon. You were here like a
Okay.
person.
Okay. Myotonic dystrophy is a genetic disorder caused by expansion of trinucleotide repeat, which occurs when a series of three nucleotides in repetition and replicated incorrectly, and too many repeats are included in the too many repeats are included in the replicated product. Other conditions caused by trinucleotide repeat expansion include Fragile X syndrome, Huntington disease, Friedreich ataxia, myotonic dystrophy. Myotonic dystrophy has several phenotypes, but all are characterized by the muscle weakness and the myotonia, defined as delayed relaxation of normal contraction of the muscle, as evidenced by the patient's mother have difficulty in releasing her grip. Classic myotonic dystrophy presents between age 10 to 30, with muscle weakness, myotonia, cataract, frontal balding, cardiac arrhythmia, and hypogonadism. However, symptoms onset at birth is also common. Symptom onset at birth is also common, and can include hypotonia, resulting in quite dry poor moro reflex and absence of reflexes. Respiratory infections, respiratory difficulties, feeding problem, and delayed development. The most frequently affected muscles is the facial muscle, sternocleidomuscle, distal forearm muscle, including hand muscle and ankle dorsiflexions. Life expectancy is reduced for patients with classic myotony, and premature death is most commonly caused by respiratory or cardiac dysfunction. Okay.
Okay. Next. 82, no, 88 woman remains hospitalized one day after undergoing 8-hour total hip replacement. She's BMI is fine. The temperature is fine, pulse is fine, respiration fine, BP high. Examination shows edema of the left gluteus maximus and palsy of the sciatic nerve. Urinary catheter is in place and contains red color urine labs. Sodium, believe that is normal. Let me double check. Yes, potassium is high. Chloride is normal. Bicarb is low. Calcium is, I believe that's low. Yeah, low. Creatinine high. Creatinine kinase, I believe is high. Phosphorus, I do not know. Alk phos, it is high. Urine, blood, 2 plus protein, 2 plus RBCs, 4, and no white blood cell. Phosphorus, I believe, is high, but I cannot see it here. Oh, right here. It's normal. Which of the following is the most appropriate next step in management?
It is like, look, after this surgery, there is creatinine kinase is very high. So there is
Mm-hmm,
muscle breakdown
mm-hmm,
and there is urine. So it looks, and there is red color urine, looks like rhabdomyolysis.
mm-hmm,
Okay. So rhabdomyolysis refers to abnormal breakdown of the skeletal muscle tissue can occur in multiple cases. The most common, which are crush or compression injuries along the compression injuries along with prolonged immobility, excessive exertion, alcohol use, medication, and exposure to toxic substance. The breakdown of skeletal muscle myocytes resulting in the breakdown of skeletal muscle myocytes resulting in the release of myoglobin and creatinine kinase into the systemic circulation. Increased creatinine kinase can be used as a marker to evaluate for the presence and the progression of rhabdomyolysis. The abnormal release of myoglobin can cause nephrotoxicity leading to an AKI, leading to an acute kidney injury from acute tubular necrosis. This patient has electrolyte derangement including hyperkalemia are common in rhabdomyolysis as intracellular ions are released in the interstitial space and ultimately return to the circulation. Hyperkalemia, hyperphosphatemia. So hyperkalemia, hyperphosphatemia, phosphorus is high, isn't it?
mm-hmm.
So hyperkalemia,
Oh,
hyperphosphatemia,
no, it's not high. You mean in the question? No, it's normal.
normal phosphate is how much? Mm,
It was like 3 to 4 or something. 3 to 4.5.
okay, so 3 to 4.5. So okay,
Mm-hmm.
hyperkalemia, hyperphosphatemia, and hyperuricemia. um, Hyperuricemia and hypocalcemia are common disturbance in rhabdomyolysis. Treatment of rhabdomyolysis, like IV hydration, making the administration of IV saline most appropriate next step for this patient. Uh, this intervention will assist in the clearance of myoglobin from the kidneys plus restoration of the normal electrolyte balance, limiting nephrotoxicity in case where hyperkalemia is present. An ECG should be obtained to assess the cardiac electrical disturbance that may require emergent treatment. Okay.
67 men brought to the ED because of a 2-day history of confusion. Wife says he's forgetful and disoriented to time and place. He has small cell lung cancer, type 2 diabetes, hypertension, medication, lisinopril, and metformin. He smoked 1.5 pack of cigarettes 45 years, quit 5 years ago. Drinks like 6 to 7, 12-ounce beers weekly. I don't know, I think that's normal. No, I think that's a lie. On arrival, he has a generalized seizure. He's unarousable, blood pressure. I guess that's fine. All the vital signs normal. Exam shows normal skin turgor. There is no edema. Neurologic exam is fine. Lab sodium is pretty low. Potassium
So
is
sodium for
normal.
CNS.
Urea is normal. Glucose pretty high. Creatinine normal. Uric acid, I do not know. Urine sodium, I believe that's high. I think the normal is 40. Osmolality, I believe that's high. I don't remember what was the normal. Following admission to the hospital, which of the following is the most appropriate next step? Let me see if I can find Uric
Okay,
acid.
can you remember that box? Like
Which one?
if we find a patient with hyponatremia, first we will see the serum osmolarity, then we will see the urine osmolarity. In here, urine osmolarity is 650, not less than 100. If it is less than 100, it is PM, like primary polydipsia and like malnutrition, beer drinking, potomania. So it is more than 100. Then
Mhm.
we will see the urine sodium. If urine sodium is more than 25, then the three cause volume depletion. Uh, there is, as far I remember, like SIADH, uh, aldosteronism. Okay, I forgot that box. Okay, so we know in here we will just give 3% saline because sodium is very low.
Mhm.
So given that this patient arrives in the emergency department, generalized tonic-clonic seizure, uh, and is arousable. The most appropriate next step is IV administration of 3% saline. Why we are giving 3% saline? The goal of this patient is to restore the eunatremia, as acute hyponatremia is the likely precipitant of the seizure. Caution must be taken when considering the rate of which the administer of hypertonic saline. A rapid increase in the sodium in a patient with chronic hyponatremia can cause osmotic demyelination syndrome, also known as central pontine myelinolysis, for patients with acute hyponatremia, this is less concern of osmotic demyelination syndrome. This is osmotic demyelination syndrome, though it must be taken into consideration. According to the American Society of the Nephrology, the safe rate concentration of for chronic hyponatremia is generally considered to be less than 12 milliequivalent per liter in 24 hours, or less than 18 milliequivalent per liter in 48 hours. However, when the sodium concentration is less than 120, the correction should not be exceeded 8 milliequivalent in the first 28 hours to avoid osmotic demyelination syndrome. When acute neurologic symptoms are present, initial initial correction should only be to the point when neurologic symptoms resolves, and followed by slow gradual correction to reach the eunatremia thereafter. In general, a bolus of hypertonic saline sufficient to raise the osmotic serum sodium 4 to 6 milliequivalent is enough to prevent the further neurologic symptoms such as seizures. Therefore, this number is clinically variable. Treatment should be targeted to the patient's specific signs and symptoms. Paraneoplastic symptom, such as this patient has inappropriate ADH secretion, suspect the diagnosis. Suspect the diagnosis given in these patients and history of small cell carcinoma of the lung and hyponatremia in the lab studies. Okay.
Okay, next. 67 women admitted to the hospital because of severe shortness of breath. She has a 15-year history of emphysema. Her written advance directive state that she does not want mechanical ventilation in the event of respiratory failure. She now states that she has changed her mind and asked the physician to do everything for her, including mechanical ventilation if necessary. Her husband said that she never wanted to leave a machine. She is oriented to person, place, time, and situation. Her pulse is high, respiration high, labor BP low, exam shows diffuse respiratory wheezing, respiratory clackers. I heard all over right upper and lower lung fields, arterial blood gas, 100% oxygen mass shows pH, which is acidic, PaO2, which is, I forgot what is this. Uh, yeah, PaO2 is low, low PaCO2 is high. And this is acidic. Okay, which of the following is the most appropriate next step in patient care?
Initially, the advance directive said that nothing to do, like he does not want the mechanical ventilation. But now he changed her mind and she want to do everything like mechanical ventilation. So we can intubate and mechanical ventilate this patient.
Okay, next. 6 hours after undergoing esophagectomy for esophageal cancer, 52-year-old man BP increases from 130/86 to 180/100, so high. Despite receiving an epidural infusion of fentanyl, he rates incisional pain as 8 out of 10 on a point scale. He's receiving 5% dextrose in 0.45 saline, including fluids administered intraoperatively. His fluid balance is plus 4 liters. His postoperative urine output is 50. His pulse is high, respiration normal, pulse oximetry and room air source, oxygen saturation 100. Exam shows a dry intact incision in pattern, nasogastric tube that irrigates clear fluid. The lungs are clear, abdomen is flat, and there is exquisite incisional tenderness. The remainder of the exam is fine. His hemoglobin is concentration is low, I guess. Hematocrit is low too. The most appropriate next step in management of this patient increased BP is IV administration of a medication with which of the following from which of the following drug classes to reduce the BP? No, to reduce the BP. Okay.
Yes, to reduce the BP.
Hmm. Let's see that one coming. Mm,
So this patient with elevated blood pressure following a major operation likely has several factors. Postoperative hypertension is common entity and can be due to several underlying causes, including pre-existing hypertension, noxious stimuli, pain, bladder over distension, nausea, vomiting, hypoxia, hypercapnia, and emergence, emergence emergence from medication can given intraoperatively and hypervolemia in a patient with postoperative hypertension through a history physical examination can often be useful in elucidating the cause. The patient likely has several factors contributing to hypertension, including severe pain, significantly positive fluid balance, his low postoperative urine in low postoperative urine output may indicate that he is retaining postoperative urine output indicating he is retaining urine, which could be the another source of continuing his discomfort. Therefore, factors should all be addressed before making further decisions regarding his blood pressure. Appropriate analgesia narcotic should be administered through evaluation of his volume status should be done, and a bladder scan should be performed to determine if patient needs a Foley's catheter. Resolution of this symptom will likely result in significant improvement of the blood pressure.
Okay.
Okay.
Next, 2 pound baby has no newborn has no spontaneous bleeding following delivery at 34 weeks gestation. He's intubated and mechanically ventilated. He's admitted to the NICU. Pregnancy was complicated by oligohydranus. Temperature is fine. Pulse is fine. Examination shows flat faces. Breath sounds are decreased. Heart sounds are normal. There is no abdominal masses. Which of the following is the cause of these findings? I get to
Okay,
know
what is
brain.
your diagnosis?
The Porter
Yes.
sequence.
In Potter is pulmonary hypoplasia, oligohydramnios, twisted face, twisted skin, esophageal problem, and renal abnormalities. The Potter. Okay.
Okay.
Oligohydramnios. Okay, next. Oh, it is easy.
Okay.
If you have time, then so your problem is you miss one or two question per block.
But yeah, I
Okay.
keep that was always been my problem. I run out of
Look,
time. I
this
never,
question is very easy.
yeah.
So if you just see, then
Yeah.
you can answer this question. Okay. Time management is my problem too.
Yeah, it's going to be a problem during the exam. I always have that problem. Okay. 67 woman comes to physician because of a 6-month history of generalized itching, infection reddening, and flushing. She has hypertension, hyperlipidemia, medications, benazepam, and lovastatin. She does not smoke cigarettes or use drugs, drinks alcohol only on social occasion, temperature fine, pulse fine, respiration fine, blood pressure is a bit high. Examination of the face shows a ruddy complexion and no rash. Lungs are clear, cardiac exam fine, spleen tip is palpated 4 centimeters below the left orbital margin and is not tender. I believe that's high. There is no hepatomegaly labs, hemoglobin is that's super high. Let me double check. I believe that's high. Hemoglobin is where am
High,
I?
very high.
Very
Hematocrit
high.
is high too. Yes.
Oh,
Uh,
MCV is 110, so on high too.
yes.
Leukocyte count is high. Platelet count is high. Creatinine fine. Addition of study are most likely to show which of the following.
What is your diagnosis?
One of the polycythemia.
Yes. There is ruddy complexion. One one thing. And hemoglobin hematocrit is high. So looks like polycythemia vera.
Mhm.
Okay. In polycythemia vera is a chronic myeloproliferative disorder characterized by increased production of erythrocytes, uh, secondary of a JAK2 mutation. Leukocytosis and thrombocytosis can occur. Leukocytosis and thrombocytosis can occur in polycythemia vera. It presents with pruritus, especially after hot shower. It presents with pruritus, especially after hot shower. Secondary to increase secondary to increase mast cell production and degranulation. Therefore, increase in um, the marked increase in erythrocyte mass and hematocrit can lead to development of hyperviscosity syndrome, which presents as blurred vision, central nervous system symptoms, headache related to vascular congestion. Patients are at increased risk for venous thromboembolism. Additionally, patients can develop severe burn in the digits with red-blue discoloration secondary to blood clot formation and blood volume, next step, which is the best initial treatment for these patient symptoms. Okay, so therapeutic phlebotomy is the next is the treatment for these patient symptoms. Okay,
Okay. Um, yeah, I think I got it now. A 15-year-old boy brought to the ED 1 hour after the onset of severe abdominal pain. During the past 2 months, he has had several 30 minutes episodes of mild abdominal pain after eating fatty food. There is family history of anemia. On arrival, the pain is resolving, temperature is fine, pulse is fine, BP fine, spleen tip is palpated 2 centimeters below the left costal margin. Hemoglobin, I believe that's low. Yeah, leukocyte count normal. Reticulocyte count, I believe, is high. Um, Serum bilirubin, I believe that's high. Mm,
look at this box. I have
which one?
shared my screen regarding polycythemia.
Okay.
It would be very helpful.
So is it? Okay. Yeah.
Okay, so the main pathology in polycythemia is increased RBC mass, isn't it?
Increase habit.
Yes, this increased RBC mass.
Mm-hmm.
Okay, so in polycythemia, it may be relative, it may be appropriate, absolute, it
Mm-hmm.
may be inappropriate, absolute, it may be polycythemia vera. These four. In relative, like if there is burn or dehydration, there is decreased plasma volume only. There is only decreased plasma volume. So it happens due to burn or dehydration. Inappropriate absolute, like the lung disease, like heart disease or high altitude, and in obstructive sleep apnea, there is increased RBC mass, there is decreased oxygen saturation because and we know that lung disease or high altitude, it causes hypoxia, and hypoxia actually increase the EPO level. We know that hypoxia is causing increasing the EPO level, and there is a decreased oxygen saturation as he is in high altitude or he has lung disease, so decreased oxygen saturation. Inappropriate absolute, in inappropriate absolute, there is only increase EPO level and increase RBC mass. Increase EPO level means like getting EPO from the outside, like athletic misuse, blood doping, or androgen supplementation, and inappropriate EPO secretion due to malignancy like renal cell carcinoma or hepatocellular carcinoma. This actually increases the EPO, so inappropriately absolute. And the polycythemia vera, in polycythemia vera, there is increased plasma volume, increased RBC mass, and decreased EPO.
Mm-hmm.
Decreased EPO, why? Due to due EPO decreased in polycythemia vera due to negative feedback suppressing the renal EPO production. Okay,
Yeah. Check my screen.
okay. Now you share your screen.
was I? Oh, the 15-year-old boy brought to the ED 1 hour after onset of severe abdominal pain. During the past 2 months, he has had several 30-minute episodes of mild abdominal pain after eating fatty foods. There is family history of anemia on arrival. The pain is resolving, temperature fine, pulse fine, BP fine, spleen T palpated 2 centimeters below the left costal margin. Labs hemoglobin is low. Reticulocyte count is high. Bilirubin, total bilirubin is, where am I? High. Yeah. And direct bilirubin. So the indirect bilirubin is high. Arc force is normal. Let me double check. Where am I? Yep. AST and ALT are high. A blood smear shows fragmented erythrocytes. Osmotic fragility testing is positive. Ultrasound of the abdomen shows gallstones. Which of the following is the most appropriate next step?
Okay, appropriate next step is cholecystectomy and splenectomy. So in here there is fragmented erythrocytes, and osmotic fragility test is positive. Osmotic fragility test is done in hereditary spherocytosis, isn't it?
Spherocytosis. Okay.
So hereditary spherocytosis is a disorder of the erythrocyte membrane protein. It's a disorder of the erythrocyte membrane protein that to limits the ability of the cell to conform when passing through narrow capillary beds. This results in early removal of erythrocyte by the spleen, resulting in extravascular hemolysis, which causes normocytic hemolytic anemia. Hereditary spherocytosis is the most common disorder of the hereditary spherocytosis is the most common disorder of the membrane erythrocyte membrane, and is frequently seen in this patient of European descent. Patient positive family history positive family history is generally present. Patients typically present with fatigue, weakness, and pallor with associated splenomegaly and jaundice on physical examination. Patients are also prone to cholelithiasis as seen in this patient as a result of increased bilirubin gallstone. Lab studies are generally show anemia, indirect hyperbilirubinemia along with abnormal results of osmotic fragility test and eosin 5 melamide analysis on flow cytometry. Blood smear may show rounded erythrocyte without a central pallor. Rounded erythrocyte with a central pallor, splenic congestion, and sequestration are the hallmark of moderate to severe disease. Splenic congestion. Cholecystectomy is indicated as is splenectomy to reduce the degree of premature erythrocyte consumption like hemolysis. Extravascular hemolysis. I can see your screen.
You cannot see my screen.
Yes. Cholecystectomy is indicated as splenectomy to reduce the degree of premature erythrocyte consumption, like extravascular hemolysis and the risk of sequestration crisis.
Can you see my screen now?
Yes.
Okay. Next. A 17-year-old gravida patient at 38 weeks gestation is admitted to the hospital in labor. 17-year-old gravida patient. Okay. Contractions have occurred for 6 hours every 2 minutes, 2 to 3 minutes. The pregnancy has been uncomplicated. A fetal heart racing is shown. The cervix is 2 centimeters dilated and 90% effaced. The vertex is at the zero station. Which of the following is most consistent with these RX findings? Oh Lord. It's the tracing one. Okay, so that's the contraction. That's the thing.
Upward, the cursor you are moving, that one is fetal heart rate, isn't it?
Total heart rate, yeah.
Yes,
And this is the mom contraction.
yes.
So we're trying to see which one coincide
So
of
fetal heart contraction is within the range, like,
yeah, yeah.
and slightly higher, but within the range. So,
Yeah,
and there is like variability, and there is acceleration, spontaneous
there is
acceleration.
yeah.
Yes. So a healthy fetal heart rate is in between 110 to 160 beats per minute, and 6 to 25 beats per minute, and 6 to 25 beat per minute of variability, and spontaneous acceleration, intermittent early and variable deceleration. Intermittent early and variable deceleration can also occur through during normal process of the labor. Early deceleration is defined as gradual decrease in the heart rate, gradual decrease in the heart rate that nadirs more than 30 seconds after initiation of the heart rate decline. The nadir of heart rate occurs at the time as the peak of the uterine contraction. Early deceleration are typically caused by the fetal head compression during a normal uterine contraction. In contrast, variable deceleration are defined as abrupt decrease in the heart rate. Abrupt decrease in the heart rate of at least 15 beats per minute at that results at least 15 seconds but less than 2 minutes. They do not show a specific relation to the uterine relaxation tracing. They are caused by the umbilical cord compression that results in decreased blood flow to the fetus and increased peripheral vascular resistance and autonomic response or bradycardia. Short periods of minimum variability may also occur when the fetus is in sleep cycle. These patients tracing with fetal heart rate approximately 150 beats per minute, spontaneous acceleration, and appropriate variability is the most consistent with normal level. This one is very hard. I don't think.
What do what do you mean?
Like what are the feature we will see in, like, if it it is in between the two, like heart rate is fetal heart rate is normal and the variability of the mothers, like it is in between 6 to 25, then it is normal. The rest of the thing we will not gonna consider according to the CTG, cardiotochogram. This is the cardiotochogram, isn't it?
Yeah. Oh, so the variability is on the contractions, it's not on the fetal heart rate.
Yes, then yeah, below
Oh, okay. That was my
this
issue.
one.
Okay. Is this one? Okay,
So
because even when we were doing the questions on your word and they will say variability, but they wouldn't give the contraction. They will only give the fetal heart rate tracing, and I
no,
will
no,
try
they
to.
give the lower part also.
Oh,
The
okay.
in the question you will find, in the question of the UWorld you will find all the, like, when we have done the question like early deceleration, late deceleration, in the below there is always variability, but we do not make it as a consideration, as because the
Mhm,
fetal heart rate is enough to diagnose the early and late deceleration.
mhm. Okay.
You got my point.
Yeah.
Okay,
Okay.
okay, next.
3-year-old girl brought to the office by her mom 2 days after she suddenly stopped talking. 3 years old. The mother says her daughter has not spoken since returning from a weekend visit at her father's house. Previously, she spoke in short sentence. The patient parent are divorced, and her father has a new girlfriend who has a 4-year-old son. The patient has no history of serious illness and doesn't take medication. In the exam group, she looks at books and plays alone quietly. Vital signs normal, physical exam shows no abnormality. The patient looks in the direction of a drop object that made a loud sound in the ground, when it hit the ground. The nods or shakes She nods or shakes her head in response to questions, but does not answer open-ended question. Which of the following is the most appropriate initial step in management?
Okay. So given the patient's acute signs of regression and acute stress disorder, the physician should ascertain whether a stressful or traumatic event occurred during the patient's weekend visit with her father by interviewing the father. Regression refers to returning to a less psychologically developed state. Regression can manifest as tantrum, excessive dependency, excessive demands, loss of continence, and rarely mutism as seen in this patient. Risk factors of regression include underdeveloped coping skill, difficulty with emotional regulation, and stressful or traumatic event. Both adults and children are vulnerable to regression. Medical hospitalization is a stressor that commonly leads to regression even in patients without personality disorder. However, physical or sexual violence is a major stressor and can include regression. Patient, patients who have undergone such an event may demonstrate other symptoms of acute stress disorder, such as changes in arousal and reactivity, being easily startled as seen in this patient, intrusive thoughts or memories, and evidence of reminders of the trauma and negative moods or thoughts. If child abuse is suspected, child protective services should be notified are physicians are mandate reporters. Management may include psychological support, and if the patient experience severe and persistent symptoms that end up meeting the criteria for traumatic stress disorder, antidepressant medication. Okay.
Okay, next. 23. Man comes to the office because 4-week history of an itchy rash on his torso. He's otherwise asymptomatic, has no history of serious illness, no medication, vital signs normal, photograph of the torso is fine. Is here. Cardiopulmonary and abdominal exam shows no abnormality. Which of the following is the most
What is
appropriate?
your diagnosis just looking at the picture?
Oh, no urticaria.
Sorry?
Or no. It's not urticaria.
No, it's not urticaria.
No. How can
It,
you
it
look at
looks like
it?
urticaria,
No.
isn't it?
Yeah, 'cause I don't think you can tell the diagnosis just by looking at the picture.
Because in the stem nothing is written. You
Yeah,
you read plenty of time, you will not gonna find any clue in the
yeah.
stem. The urticaria is excluded. There is uh,
Why?
not excluded, but because there is itching. But
Wait, urticaria is not itchy?
urticaria is itchy, yes. So
Okay.
urticaria, we cannot exclude the urticaria just reading. So urticaria may be one of the differential, but it is pityriasis rosea, because we need to remember this by looking at the picture. There is no other option,
Mm,
because if you think urticaria and if there is an option like antihistamine, then we
mm-hmm,
will easily pick that option.
mm-hmm.
because this is eating. So, so we have to remember the picture as well. So pityriasis rosea is a cutaneous eruption characterized by acute onset of pruritic patch, herald patch, followed by smaller and numerous smaller macules and patches, macules and patches. Pityriasis rosea commonly involves the trunk, proximal extremities. The individual patches of Pityriasis rosea are ovoid, and their longitudinal axis are uh, long axis is often lined up with the relaxed skin tension lines on the trunk. Lesions are typically scaly and have a rim of scale around the leading edge of any new lesions. In patients with pigmented skin types, pityriasis rosea may present with raised lesion hyperpigmentation. Pityriasis rosea may occur following viral infections such as human herpes virus 6 or 7, and though a case is not always elucidated, pityriasis rosea self-resolves 6 to 8 weeks without treatment. Topical corticosteroid may be used for symptomatic management of pruritus. Okay,
Jesus. Okay, so I guess we need to know what it looks like. Okay.
yes, it looks like herald patch.
Okay. Next.
The skin is
82
hard.
80 82-year-old woman brought to the physician by her daughter because she has not had a bowel movement for 2 weeks and has had loss of appetite for 3 days. There is no history of rectal bleeding or change in stool color or caliber. 1 year ago, test of stool for occult blood was negative. Examination shows large exophytic cauliflower-like lesions between vaginal and rectum. Rectal exam shows fecal impaction. Biopsy specimen of the lesion is most likely to show which of the following.
Okay,
Cauliflower. Mhm.
so it's look like cauliflower like and exophytic valvular mass. So this patient presenting with constipation in the setting of a large exophytic valvular mass raising concern for valvular carcinoma. The most frequent underlying histopathology of valvular carcinoma is squamous cell carcinoma. Histopathology of valvular carcinoma is squamous cell carcinoma, and its incidence is the greatest in patients between the ages 55 and 85 years. Most commonly, most commonly it presents with a valvular nodule, papule, or plaque that may be otherwise asymptomatic. Although the lesion can also be pruritic and friable, leading to ulceration, bleeding and pain in rare instances such as this patient seen in this patient, squamous cell carcinoma of the vulva can present as a verrucous carcinoma with large cauliflower-like growth. So squamous cell carcinoma, verrucous carcinoma with large cauliflower-like growth that can be locally destructive. In addition to the culprit lesion, a physical examination may disclose inguinal lymphadenopathy. Risk factors include infection of the HPV, smoking, immunosuppression, chronic inflammation, lichen planus, and a history of cervical cancer. Diagnosis is made on the biopsy of the lesion. However, further evaluation should include cervical cancer screening, as concurrent cervical carcinoma is common, and abdominal pelvic imaging to determine the extent of the disease. Treatment include surgical excision in addition to chemoradiation. Okay.
Can you B?
Yes. Uh, Hyperplastic dystrophy refers to chronic inflammatory changes of the vulva. These can be caused by lichen sclerosis, dermatitis, or chronic irritation. Presenting symptoms differ based on the understanding cause due to dystrophy and include erythema, skin thickening, color changes, or pruritic, painful lesion, and dyspnea. A large cauliflower-like lesion is most likely squamous cell carcinoma of the vulva than hyperplastic dystrophy. Okay.
Mm. Can you read
Signet
signet?
okay. Signet ring cells are most commonly seen in the histopathology of gastric and colorectal cancer. Signet ring. Although they can rarely be seen in other types of cancer like bladder and thyroid, gastric cancer classically presents at an advanced stage of anorexia, weight loss, nausea, abdominal pain, whereas colorectal cancer most frequently causes change in the stool caliber with occult gastrointestinal bleeding and consequent iron deficiency anemia. Consequent iron deficiency anemia. While colorectal cancer can cause rectal mass and is unlikely to be large verrucous lesions such as this patient. Additionally, in this patient, okay, and this patient has negative screen of fecal occult blood. Next,
Okay. 80 women with hypertension and dementia, Alzheimer type, brought to the ED by paramedics from the nursing home where she resides because of 1 day history of vaginal bleeding. The patient is nonverbal. The staff member who accompanied the patient reports the patient fell 2 nights ago while moving from the shower chair to the bathtub. The bleeding was noted today while a nurse aide changed the patient absorbent pad this morning. Medication are donepezil, amlodipine, aspirin. She is BMI is 18. Vital signs and oxygen saturation is normal. Exam shows ecchymosis over the upper extremities and thighs. The ecchymosis are more severe on the right thigh than the left. Genitourinary exam shows ecchymosis over the labia majora and torn labia minora at the 7 o'clock position with minimal bleeding. Her hemoglobin concentration is 12. I do not know if this is normal. I think it's normal. Which of the following is the most likely explanation of these findings? I think hemoglobin is fine.
okay, this patient genitourinary examination show ecchymosis over the labia major and torn labia minora. So looks like abuse.
Mhm.
Okay,
Can you read why it's not E?
okay, it's not why it's not von Willebrand disease. Von Willebrand disease is a bleeding disorder mm, that is caused by quantitative or qualitative abnormalities of the von Willebrand factor, which binds platelet and subendothelial collagen in primary hemostasis. Impaired platelets adherence leads to prolonged bleeding time. Impaired platelet adherence leads to prolonged bleeding time. It can present with epistaxis, gingival bleeding, petechiae, easy bruising, and menorrhagia. It would not present the labial laceration, which are present in this case. Okay, the form of presentation, like it cannot cause laceration.
Okay. Next, 67 woman comes to the physician for the second measurement of his no he's 67 men second measurement of his blood pressure. He had a blood pressure of 165 over 105 in his right arm 9 days ago. He takes no medication. He has smoked 2 packs of cigarettes like for 35 years. Today his BP is 160 over 100, so still high in the right arm, and 105 over 65 in the left arm. Okay, the remainder of the exam is fine. Which of the following is the cause of the BP findings?
Okay, BP difference in both two arms. Okay. So subclavian artery atherosclerosis. Subclavian artery atherosclerosis is the common cause of subclavian artery stenosis. Is the most common cause of subclavian artery stenosis. Is one of the common cause of peripheral arterial disease. Most common risk factor include age, typically 60 years or above, diabetes mellitus, hyperlipidemia, hypertension, smoking. Patients classically presents with claudication to the affected extremity. Patient classically presents with claudication of the affected extremity, pain at rest, and in severe cases, possible discoloration of the extremities. One phenomenon of subclavian still syndrome is minority of the patient with subclavian artery stenosis occurring proximal to the region of the ipsilateral vertebral artery. In subclavian still syndrome, blood flows from contralateral vertebral artery through the basilar artery and then retrograde fashion down in the ipsilateral vertebral artery through the affected subclavian artery. Patients with subclavian still syndrome may present with vertigo, nystagmus, syncope with upper extremity exertion. Patient physical examination may show pulse and a blood pressure difference between the right and left upper extremity, as well as temperature differential. Duplex ultrasonography with color flow imaging or CT angiography to use to diagnose subclavian artery atherosclerosis. Treatment involves endovascular technique as stenting and angioplasty, and open techniques such as vascular bypass. What happens in subclavian still syndrome?
I never know. If I see the picture, I can know, but I never know how to
Okay,
explain.
so
Subclavian steel syndrome.
okay,
Like usually, if you see it, you can
you see my
figure
screen
it out. Oh
now.
yeah, you see
Now
it.
you
Let me see
describe.
it.
I
Oh
was, I
Lord.
was, I was doing world like I was getting wrong this question. So,
Let me
so
see. Okay. Oh, I've never seen that. Okay. Uh. Okay. So normally
this
the
is the
art,
place where there
the
is
one that is
stenosis.
blocked. Uh
Yes.
huh.
So
Uh
then
huh.
what happens?
So I guess the blood goes from here from the aorta to the right vertebral artery, and then it goes up to this one. Which one is this one? Yeah, the right vertebral artery. It goes up, and then I guess it goes back here, and it comes back to the left vertebral artery, and then instead of going back down, it goes back here because this is blocked. So it goes
Okay,
back here.
it goes through the
Yeah,
subclavian artery.
it goes
That's
up.
why there is a high blood flow. That's why there is high blood pressure. Like look in normally uh,
Uh-huh.
the blood supply from right vertebral artery goes to the basilar artery, and
Uh-huh.
then the brain gets the supply, and the
Mm-hmm.
left vertebral artery uh, goes to the basilar artery, and the brain gets supply. But in here, as there is stenosis, the right vertebral artery, there is a backflow or there is reverse flow.
Like it doesn't go up,
It
it just
does okay. It does not
uh,
go up, and it
uh,
goes the opposite direction where there is the stenosis.
uh-huh.
Okay,
So
then
here there is blood pressure where on this side or this side? High
what?
blood pressure on this
High
side
blood
or on this
pressure should maybe in the left side. Okay, I'm reading this, then
side?
you
Okay.
will understand. Okay,
Okay.
look at this question. This 68-year This 68-year-old man comes to the emergency department due to severe dizziness while playing tennis an hour ago. He
Mhm.
says that he had a spinning sensation. He had a spinning sensation accompanied by nausea and vomiting, and the symptoms have now subsided. The patient has a brief the patient has had a brief episodes of dizziness in the past, especially when performing the vigorous work with his arms. He has no he has also experienced heaviness and fatigue on the left arm on exertion. So he's experiencing heaviness and fatigue on the left arm on exertion. So this is the left arm. So the patient has a history of hypertension, hyperlipidemia, type 2 diabetes mellitus. Blood pressure on the right arm is 140 and the left is 100 by 74 on the left, and the pulse is 82. A systolic bruit is heard at the asystolic bruit is present at the base of the neck just above the clavicle. The base of the neck just above the clavicle on the left side. Cardiac auscultation disclosed fourth heart sound. There is no extremity weakness or sensory loss. Which of the following is the most likely symptoms? So according to this, right-sided blood pressure is higher.
Can you read the explanation?
Yes, yes.
Mhm.
This patient likely has subclavian still syndrome due to atherosclerosis of the left subclavian artery. Due to atherosclerosis of the left subclavian artery proximal to the origin of the vertebral artery. Proximal to the origin of the vertebral. Okay, proximal to the origin of the vertebral artery. Significant stenosis or occlusion lead to decreased pressure in the distal subclavian artery. Decreased pressure in the distal subclavian artery and reversal like reversal or steal of the blood in the ipsilateral vertebral artery. So steal of the blood of the ipsilateral vertebral artery, the left subclavian artery are commonly affected than the right due to sharper curvature and more turbulent blood flow, leading to atherosclerosis. Most patients with subclavian artery stenosis are asymptomatic. When asymptomatic, patient most commonly have symptoms of ischemia of the affected arm, pain, fatigue, paresthesia. Less commonly, patients with concurrent atherosclerosis of the circle of the Willis may develop symptoms of vertebrovascular ischemia, dizziness, ataxia, disequilibrium, exercising the effect Exercising the effect of upper extremity causes arterial vasodilatation and a further lowering of the distal pressure, which may exacerbate vertebrophyseal symptoms. Physical examination often demonstrate a significant lower brachial systolic pressure, more than 15 millimeter mercury in the affected arm. So physical examination often demonstrate a significant lower brachial artery pressure, more than 50 millimeter in the affected arm, and a systolic bruit on the affected site. A fourth heart sound may be found due to left ventricular hypertrophy. Diagnosis made by Doppler ultrasound, magnetic angiography, and treatment involves the lipid lowering intervention, smoking cessation, sometimes stent placement. Okay, now you explain.
Um, okay, so I guess the arm that has the stenosis is not doesn't have high blood pressure. That's the one that has the low blood
Mm,
pressure, I think.
yes.
And the other one is the one that has the high blood pressure. And I guess even if it's called subclavian steal syndrome, it's actually the vertebral artery that's doing the stealing. It's not really the subclavian artery. You get what I'm saying?
Yes,
So it's the yeah, it's actually
and
the because that was
there is stealing of the blood from the right side of the, like right side from right vertebral artery
uh-huh,
towards the
uh-huh,
left, as there is stenosis. So there he is, like left subclavian artery is stealing the blood from the right,
uh-huh,
as well as as well as in here the left side there is low blood pressure, and
mm-hmm.
there is low, what can I say, and there is a systolic bruit.
Throw it on the side that has the stenosis. And then we can just assume that because the blood doesn't go to the brain, like you see that it just uh, flows down. That's what causes the dizziness.
Yes,
We
as the
can
blood is
assume.
not going to the brain, that's why there is dizziness. Okay,
Okay.
okay,
So
now
subclavian syndrome is vertebral. So the carotid artery doesn't have anything to do there. It's the vertebral artery
yes,
and the
it is the
subclavian.
vertebral artery.
Okay. Got it. Got it.
Okay,
Oh, wait. In your question, the answer you chose, why is not the answer you chose?
okay, I'm again sharing.
Sorry.
You can see now.
Yeah.
Okay, it's not D. Like internal carotid artery stenosis can be asymptomatic due to collateral circulation and may cause transient symptom of ocular or cerebral ischemia like amaurosis, fugax, and limb weakness. So internal carotid artery stenosis can cause amaurosis, fugax, and limb weakness. Dizziness and disequilibrium are consistent. So dizziness, disequilibrium consistent are more consistent with vertebrovascular ischemia, like cerebellar ischemia. So dizziness, disequilibrium, cerebral ischemia,
Okay. Okay. So signs of stroke then is internal carotid artery stenosis. If it's
stenosis.
dizziness and ataxia, I guess is vertebrovascular, whatever. The still syndrome. Okay. Got it. Got it.
Okay, look this option also.
Mm-hmm.
Vertebral artery stenosis can cause
Mm-hmm.
symptoms of dizziness and disequilibrium. However, symptoms of arm ischemia or a blood pressure difference in the upper extremities is not expected. Okay.
Yeah, because the vertebral artery only supplies we saw up there that it supplies the brain, so it wouldn't cause anything to the arms.
Yes.
We saw here that it goes to the brain, so it wouldn't cause anything to the arms. For it to go to the arms, it has to affect, I guess, the which one? The subclavian,
Yes.
right? Right? Or no? Am I wrong?
No, no, you are right. Like uh, the the supply starts from here, isn't it? And the ascending
Mm-hmm.
arch of the aorta,
Mm-hmm.
there is
Mm-hmm.
brachiocephalic, common carotid, and subclavian. So
Mm-hmm.
for vertebral artery to uh, cause the BP difference, then in here the arch of the aorta where the arching is start, it has to be blocked. Then
Mm-hmm.
everything will happen. This
Mm-hmm.
right here, if they are, but I don't think that such big stenosis is present, or it is
Mm-hmm.
possible to such big atherosclerotic plaque to block this huge circulation. Okay,
Mm-hmm. Okay, okay, okay.
okay.
Okay. Next, let me share. What is the thing? Oh, wait, you already read this, right? Yes.
Sorry.
You already read the explanation
Yes.
here. Mhm. 18-month boy from Afghanistan who immigrated to the US with his family 2 days ago is brought to the ED by his mom because of a 6-hour history of fever and difficulty breathing. The mother says he previously was doing well, medical history is fine, he has not had contact with anyone known to be ill. He received no medication, immunization status is unknown. He is sitting on his mother's lap, leaning forward and drooling. That's the key.
So what
He
is the
appears
diagnosis?
the
Think,
epiglottitis.
yes, think about that baby who is leaning forward and drooling in the picture in the world, and there is
Mhm.
difficulty in breathing. That one is epiglottitis. Okay.
He appears to be in significant rest distress. Vital signs: temperature is high, pulse high respiration high, blood pressure low. Pulse oximetry is 95. Physical exam shows stridor with without auscultation. Which of the following is the next step?
Okay. The next step in epiglottitis is like save the airway. Doing endotracheal intubation should take place in the operating room under direct visualization with a laryngoscope if the patient is stable enough to permit transfer out of the emergency department. Okay, in
Where are
this,
you reading? Oh,
I okay, this one like first line emergency treatment is to emergently establish a protected airway through endotracheal intubation.
mm-hmm.
Through endotracheal intubation in the setting of epiglottitis, endotracheal intubation should taken place in the operating room under direct visualization with a laryngoscope. If patient is stable enough to permit transfer out of the emergency department. Transfer out of the emergency. What does it mean? So if it is possible, then we can do the. I don't understand the last line. In the setting of epiglottitis, endotracheal intubation should be taken place in the operating room. I got it. Got it. Under direct visualization with a laryngoscope. If the patient stable enough to permit transfer out of the emergency department. Okay, if patient is able to transfer and permit out of the emergency department, then you should transfer the patient to the operating room for endotracheal intubation.
Okay. Okay.
So
Can you
and
repeat?
they are like okay. Yes, indirect laryngoscopy would permit the potential visualization of the larynx and airway with the significant threat of airway compromise. Direct laryngoscopy in the operating room for endotracheal intubation uh, uh, is more appropriate.
Okay.
And is there any other option? Any other
Mm,
treatment? No. So is there
no.
any option like if suppose the airway is blocked and
Mhm.
then is there any tracheostomy or cricothyroidotomy? Is there any such type of option? If the uh, uh, if the airway is blocked, so you are not able to do the endotracheal intubation, then what you will do? Is there anything like that?
I've probably, but I've never seen a question of that. Usually they will tell you, okay, he comes with epiglottitis, what's the next thing to do? And it's usually like intubate. That's I never seen it. I suppose that if you cannot intubate, you will do just tracheostomy straight up.
Mm,
But I've never seen like one of those questions.
okay, next.
57 men with pancreatic cancer is admitted to the hospital because of 5-day history of moderate epigastric pain that has not responded to oral morphine therapy. On admission, IV morphine is began. The nurse calls to report that 3 hours ago she mistakenly administered 5 milligrams of morphine instead of the prescribed zero point 0.5 milligrams. The patient is sleeping comfortable and is easily aroused. Respiration are fine. BP is fine. Pulse oximetry on room air shows oxygen saturation 98. Exam shows no abnormality. In addition to reporting the incident to the patient safety committee, which of the following is the most appropriate next step?
Okay, no additional management indicated for this patient. Hydromorphone hydromorphone is an opioid agonist, a short duration action for 2 to 3 hours. If patient were experience opioid toxicity, if this patient were to experience opioid toxicity, he would have already shown sign. Opioid toxicity presents with sedation, respiratory depression, bradycardia, hypotension. Instead, he is easily aroused and has vital signs with normal limits. No further medical management is necessary. Okay, I don't get it.
Oh, oh, it's just because he got the kind of extra morphine, but he's not showing any signs of intoxication. Because opioid, the respiratory rate will be low and all that,
Yes.
the meiosis and all that, but he's not. The vital signs are normal. Everything is normal. So I guess he doesn't really have an intoxication. She gave him more, but it's not really showing any kind of intoxication. So we don't need to do anything. I think that's what they're saying.
So in opioid toxicity, like in hydromorphone, if patient comes and no symptoms, we'll give some hydromorphone to see the response of this patient.
No, what do you mean? I don't understand. Like the patient was given higher. He
Yeah,
was supposed to get 0.5 and he's getting 5. So
5,
he's
yes,
getting high by mistake. So now the nurse, they're going to check if he's getting intoxicated because he got way higher than what he was supposed to get. But now they're checking and everything is normal. So
normal.
it seems that yeah, he's not, even if he got higher than what he was supposed to get, he's not showing any symptoms of intoxication. That's what they're saying. So if he's not showing any symptoms, yeah, we reported to the committee that I made this mistake, but we don't need to do anything to the patient because he's not showing symptoms. If he was showing symptoms of intoxication, I guess, yeah, you will have to give naloxone, I'm guessing. Yeah.
Okay, administer naloxone and transfer to the ICU and begin oxygen therapy and transfer to the telemetry unit are unnecessary. Uh, Naloxone is a short-acting opioid antagonist to reverse the opioid overdose. Patients are commonly placed on oxygen and transferred to the telemetry unit in case of medication overdose. However, this patient is not showing opioid toxicity. Okay.
Yeah. Next. 16-month old brought to the physician by his mom for a follow-up exam. 1 month ago, he completed a course of antibiotic therapy for ear infection. His mother reports he has a 2-day history of irritability, decreased appetite, and difficulty sleeping. He has been hospitalized for pneumonia twice during the past 9 months. He appears irritable, his temperature is high, pulse is normal, respiration normal, BP is super low. Skin exam shows no abnormality. Exam of the right ear shows an erythematous, bulging tympanic membrane. Labs show leukocyte count super high. I think segmented neutrophils are high. Lymphocytes is below, and monocytes, I don't know. Additional serum studies are most likely to show what are the following. So he's a baby. So he cannot be CV'd. Mm,
Yes, Bruton for babies.
But for babies. Yeah. And he
So,
has a bunch of sinopulmonary infection.
yes. So, decrease B lymphocyte concentration, decreased B lymphocyte concentration, a feature of Bruton's X-linked agammaglobulinemia caused by the defects of Bruton BTK gene. BTK is necessary for all stage of B lymphocyte development and proliferation, and deficiency of these enzymes results in B lymphocyte development and results in failed B lymphocyte development, as B lymphocytes are responsible for secreting immunoglobulins such as these um, secreting immunoglobulin once they differentiated into plasma cell. A defect in B lymphocyte maturation leads to death of the plasma cell. Low immunoglobulin concentration of every class, including IgA, gain. Patients present with bacterial infection due to impaired humoral immunity, especially after first 6 months of life, when maternal IgG concentration when treatment is IVIG, and recipient of all available immunoglobulin other than live vaccine, which are contraindicated in this population. Live vaccine is contraindicated. Mm, these patients have evidence of recurrent bacterial ear infection and should receive antibiotic in addition to IVIG. Okay.
Can you read C?
Yes. Uh, IgM antibody concentration and the paucity or absence of immunoglobulin from different class are the hallmark of hyper IgM syndrome. This is caused by X-linked recessive defect in CD40 ligand on T helper cell and a ligand that interacts with B lymphocytes to induce class switching of the immunoglobulins. Patients present with severe pyogenic infection as well as infections with opportunistic organism, B and T lymphocyte population concentration are normal, unlike in this patient. Moreover, this patient infectious history does not match the severity or type seen in hyper IgM syndrome. Okay.
Okay. Next. 27 men comes to the physician because of a 3-day history of fever, bloody diarrhea. Episodes of diarrhea preceded by abdominal pain. He has had no weight loss or rash. He takes no medication. Temperature is a bit high. Pulse is normal. Blood pressure normal. Abdominal exam shows diffuse tenderness with no rebound or tenderness or guarding. Bowel sounds are increased. Rectal exam shows no abnormalities. There is no blood mm, or stool in the rectal wall. Which of the following is the most likely cause?
Okay. This is Campylobacter jejuni because in here Giardia lamblia causing steatorrhea. Norwalk virus can cause diarrhea. Adeno is diarrhea, and ETEC is also watery diarrhea. Only Campylobacter jejuni causing the bloody diarrhea, isn't it?
Mm-hmm, mm-hmm, mm-hmm.
And Campylobacter is associated with GBS, but there is no GBS feature like
Mm-hmm. Mm-hmm.
decreased deep tendon reflex. Okay.
Okay. Next. 15-year-old boy brought to the ED after a football practice because of 45-minute history of dry red blood in his urine. He has no history of serious illness, doesn't take medication, pulse is high, blood pressure is normal, all the vital signs are normal. Exam shows no ecchymosis or palpable tenderness or abdominal distension. There is moderate tenderness to palpation of the left flank. Which of the following is the most appropriate next step in diagnosis? Mm,
Looks like the during football practice there is traumatic injury, like
for what?
traumatic kidney injury. So, abdominal CT scan is the most likely to confirm the kidney laceration, hematoma, or other traumatic injury, kidney injury in this patient. Football practice places in patients at risk of blunt abdominal or flank retroperitoneal trauma. This patient sustained trauma to the flank leading to blunt kidney injury, driven it to the retroperitoneal location, and isolated kidney injury may not cause abdominal pain Tenderness, peritonitis on examination. Kidney injury most commonly presents with gross hematuria and diagnosed with CT scan of the abdomen with IV contrast. Minor injuries such as contusion, laceration, and small hematoma may heal without intervention. Large injuries with active extravasation injuries with devascularization or direct large vessel injuries in the with interperitoneal extension or injury in the urinary tract obstruction may require surgical or procedural intervention. Okay,
You read B and D.
yes. Measurement of C3 or C4 concentration is for glomerulonephritis, post-streptococcal glomerulonephritis presenting with urinary RBC or RBC casts, which typically occurs 2 to 6 days after infection with a group A streptococcus hemolytic streptococci. Results of lab studies show low serum C3 and C4 concentration and positive anti-streptolysin O and anti-DNA titer. A streptozyme test measure the antibodies to group A streptococcus antigens such as anti-streptolysin O and anti-DNS. This patient has gross hematuria, not microscopic hematuria. In addition, this patient hematuria in the setting of blunt trauma making kidney injury more likely. And the urine culture would be helpful for patients with UTIs, which typically presents with dysuria, urinary frequency urgency, and patients have flank pain, nausea, vomiting, and fever if the infection ascends to the kidney and can cause pyelonephritis. Okay.
67 men with squamous cell carcinoma of the lung comes to the office for follow-up after 10 days after receiving his first dose of chemo with carboplatin and etoposide, followed by radiation therapy. He had nausea and vomiting for 2 to 3 days following the treatment. He now feels weak but well overall. Vital signs are normal. Exam shows no abnormality. Results before treatment, hematocrit was normal. Let me open my thing. Before treatment, hematocrit was his a man was low, a little bit low. Now it's even lower. Leukocyte count
Count is
was
very low.
very low. Neutrophil very low.
Lymph
Eosinophil is absent. Oh, lymphocyte it increased somehow.
increased, yes, and platelet count is low.
It's low.
So there is anemia, thrombocytopenia, and leukopenia. Everything is low.
Which
So
of the
they
following is the most appropriate next step in management of the pancytopenia?
so we should give the GSF colony stimulating factor, which will produce the which will produce the blood cell and correct the condition. Okay, myelosuppression is an adverse effect of several cytotoxic chemotherapeutic agents, including these etoposide and doxorubicin, paclitaxel, and hydroxyurea. A number of non-chemotherapeutic agents, trimethoprim, sulfamethoxazole, antithyroid, methimazole, antipsychotic, clozapine, some antiarrhythmic, also commonly implicated. Presentation can include cytopenia, including neutropenia, granulocytosis, anemia, thrombocytopenia. While patients are often asymptomatic, they may present with severe infections and sepsis as a result of neutropenia. Neutropenia is defined as neutrophil count. Neutropenia is defined as absolute neutrophil count of less than 1500. Agranulocytosis indicates neutrophil count less than 100. The patient's neutrophil count of roughly 60 60 is consistent with the diagnosis. The risk of spontaneous infection increases when the neutrophil level drops to 500. management immediate withdrawal of the implicated medication, treatment of the underlying infection, administering of the granulocyte colony-stimulating factor, and is associated with quicker recovery and shorter duration of hospitalization. Okay.
Can you read D, E, and F? D, E, F.
Transfusion of the leukocytes is very rarely used to treat severe refractory infection in leukopenic patients. Data on safety and efficacy are limited. This patient does not show any signs of infection and stimulation or production of his granulocyte colonies of his own granulocyte with GCSF is the most appropriate next step. Treatment of pancreatic cell is usually indicated when hemoglobin drops below 7, which correlates with hematocrit approximately 21%. This patient's hematocrit is 32%, indicates that his hemoglobin is above the transfusion threshold. Okay.
F.
Okay. Transfusion of leukocyte is very rarely used to
No,
treat.
F. F.
Okay.
Mhm,
Transfusion of platelet
mhm,
is indicated in patients with mm, platelet less than 50,000 in the setting of major bleeding or surgery, or in a stable non-bleeding patient with platelet less than 10,000. This patient's platelet count 34,000 above the transfusion threshold for non-bleeding patient. Non-bleeding. Okay, non-bleeding patient it is 10,000, and for bleeding patient less than 50,000 is the cut mark. Okay,
mhm. Okay.
non-bleeding.
Okay. Leukocyte count is not done. Red blood cell will be less than 21 hematocrit and platelet less than 10,000. Okay. Can we stop here for
Yes.
today? Okay. I will see you tomorrow.
Okay.
Thank you.